Hello, everyone. I'm just going to wait until 8 o'clock to get started. I just started the session just to ensure it gives enough time to people to join. I see about 24 people have joined so far. I'm going to give a little bit more time before I get started and before I start talking. So I just put a comment in just for people to know. I'm going to be giving a short presentation, and this will be regarding COVID-19 and the PBC patients. After the presentation, I'm going to do a new live session. That's where I'm going to be doing the question and answer part of my presentation. So after this presentation, I'm going to go offline and then start a new live session where questions can be put in the comments and I'll answer them live. All right, I'm going to get started now. It's 8:02. I see a number of people saying hi, so I'm guessing everyone can hear me. My name is Magnus McLeod. I know some of you out there, and I'm an assistant professor at the Dalhousie University. I'm going to start out by saying what we do here in the central zone of Nova Scotia and how we deal with COVID. Any patient who has symptoms or has close contacts to patients with this COVID-19 virus, they are referred to a primary assessment center. If patients have any red flag symptoms, they're then moved on to what we call the secondary assessment center. In the secondary assessment center, we determine if admission to hospital is warranted, and sometimes if that's the case, they get admitted to either the COVID ward, which would be for ward-based treatments, oxygen, and if patients require more higher levels of care, they might go to the COVID IMCU, which is the intermediate care unit, or the COVID ICU, which is the intensive care unit. I'm involved with assessing patients at the level of the secondary assessment center, the COVID ward, and the COVID intermediate care unit. If patients are determined good enough to be discharged from either of those places or the ICU, there is a COVID virtual outreach team, which I'm a part of as well, where we deal with patients who have COVID as a diagnosis and help them through the struggle of whether or not they need to come back to hospital or not. So I just wanted to give you an outline of what I do in regards to COVID before we get started. So in this presentation, I'm going to kind of go through some of the frequently asked questions. It's more of a broad overview. So the first question is, just to kind of get us all on the same page, what is the novel coronavirus? And when we say novel, that just means this is a new coronavirus that hasn't previously been identified. The virus causing coronavirus disease 2019 is what we are classifying as COVID-19. There's a number of coronaviruses out there, and you can see the 229E, the NL63, the OC43. There's a whole bunch of them, and they mainly cause cold-like symptoms and mild symptoms in a normal person. We've had issues with the MERS, or the Middle Eastern Respiratory Syndrome, and SARS, the Severe Acute Respiratory Syndrome, both types of coronaviruses. And sorry for the bottom one in the fancy colors. This is the SARS-CoV-2, or the COVID-19 virus, the new coronavirus. And it's just a type of coronavirus that seems to be different than many of the mild ones, and even different from MERS and SARS. How is this virus spread? It's mainly spread through respiratory droplets that can land in people's mouths and their noses and possibly inhaled into the lungs. And this occurs when there's close contact, and what's usually cited is about 2 meters or 6 feet. What are the symptoms of COVID-19? The symptoms are your kind of classic viral illness symptoms. Tiredness, high fever. It's usually a dry cough. There can be shortness of breath. There can be a sore throat. There can be headache. And there's other symptoms that you can, if you look up COVID-19 symptoms, nausea, vomiting, diarrhea. And the symptoms can become more severe. These are more of the mild symptoms. You can get pneumonias, you can get difficulty with your heart pumping enough blood, and you can get severe difficulty of shortness of breath. The next question I hear a lot is, should I be tested for COVID-19? And there's a very good website. It's a Canadian website. It's the COVID-19 symptom self-assessment tool. And it's based on your province. So you just plug in all the information, and it pretty much tells you what to do. My big questions for all the patients I see in all the different areas of my COVID assessments, there's a number of questions I always ask. Are you having severe difficulty breathing? Are you having severe chest pain? Is it difficult to wake up? Are you feeling confused, or do you feel like you're going to lose consciousness? If any person has any of these symptoms, that's considered a red flag. And so it's important to go to the closest emergency room or call 911 in those situations. So what is the current situation in Canada right now? And I know some of you may know more about this than me right now because it's changing so rapidly. Before this presentation, I just kind of PowerPointed what was the closest numbers, and it's already out of date. In Nova Scotia, there's 915 cases. I just checked, there's actually 935 cases. And in Canada altogether, there's greater than 50,000 cases. Some provinces have more than others. Quebec has quite a number of cases, and some provinces have decreased in the amount of cases over time, but there's still quite a few, and we haven't kind of lowered that curve just yet. Now I'm going to kind of switch over to PBC. So what is PBC? So it stands, as most of you know, or many of you know, PBC stands for primary biliary cholangitis. This is an autoimmune illness that affects those small bile ducts within the liver, and those are highlighted in green in the cartoon beside on my slide. Over time, if that autoimmune attack of the bile ducts occurs long enough, the bile ducts can become scarred and destroyed. And once the scarring happens and all the toxins within the bile can seep into the liver, you can start getting scarring in your liver. PBC is diagnosed when someone has unexplained cholestasis, which means impaired bile flow. And we can tell that based on laboratory values, specifically the alkaline phosphatase value. And if it's associated with a positive anti-mitochondrial antibody or some specific anti-nuclear antibodies, we can make the diagnosis of PBC. Some patients require a liver biopsy, but most don't. I mentioned if the bile duct damage happens for long enough that scarring can happen. And it's important to know what stage of scarring a patient is in, and we use a number of different ways of assessing this. But in general, a patient can have no scarring, which I would consider stage 0. But once you get to stage 1, stage 2, stage 3, and stage 4 scarring, it just tells you how much damage has been done, with stage 4 scarring meaning cirrhosis of the liver. There are a number of treatments for PBC. The main and cornerstone of treatment is ursodeoxycholic acid, otherwise known as URSO or UDCA. And the newest approved medication for PBC is obeticholic acid, otherwise known as OCA, OCA, or Ocaliva. Some off-label treatments are used, such as fibrates, most commonly bezafibrate, but some patients are on fenofibrate. Sorry for the spelling error. So now getting into the specifics of specifically PBC with COVID-19, one of the questions is, does PBC increase my risk of acquiring COVID-19? And there isn't really any evidence that would say that stable patients with PBC are at increased risk of acquiring COVID-19. And looking at all chronic liver diseases, there doesn't seem to be any increased risk of acquiring COVID-19 for patients with non-alcoholic fatty liver disease, primary sclerosing cholangitis, hepatitis B, or chronic hepatitis C. Does PBC increase my risk of complications of COVID-19? And this is where it gets a little bit tricky. From that Canadian website and the websites from the CDC, or the Centers for Disease Control, there are a number of conditions that kind of put you at higher risk of severe illness in regards to COVID-19. In patients who are older than the age of 65, patients who live in nursing homes or long-term care facilities, anyone with chronic lung disease of moderate to severe asthma, if you have serious heart conditions, severe obesity, if you have diabetes, if you're on hemodialysis, if you're immunocompromised in any way, or if you have liver disease. So I'm going to focus on this immunocompromised and liver disease when they mention that. So for PBC, there's 3 patient populations that I would consider at higher risk of severe illness. Those of you with cirrhosis of the liver, those who are post-transplant, and mainly I'm talking about post-liver transplant, but it could be post any transplant, and those patients who are on immune-suppressing medications. So with cirrhosis of the liver, if you're not sure if you have cirrhosis of the liver, if at any time you had jaundice from your PBC, there's a high risk that you have either advanced scarring or cirrhosis of the liver. If you've ever had ascites, which is fluid accumulation within the abdomen, if you've ever been told that you have varices, there's a high chance that you have cirrhosis of the liver. Or if you're getting ultrasounds every 6 months, we usually monitor for liver cancer with those, and we do that in patients with cirrhosis. Being post-transplant means that you're usually on certain medications that really decrease the immune system. And I've listed some of the medications on the left-hand side: tacrolimus, otherwise known as Prograf or Advigraf, cyclosporin, sirolimus, prednisone, or mycophenolate. All of these decrease your immune system and put you at a higher risk of COVID-19 complications. With PBC, there can be associated autoimmune conditions, as many of you know. Some of these conditions, such as rheumatoid arthritis, lupus, or Sjogren's syndrome, they can be treated with medications that decrease the immune system as well. I've listed some of them: etanercept, infliximab, adalimumab, golimumab, certolizumab, tocilizumab, and azathioprine. In PBC, there can be overlapping autoimmune liver diseases such as autoimmune hepatitis and IgG4 disease. And in those patients, we can treat them with azathioprine, tacrolimus, cyclosporin, prednisone, or budesonide. And if you're on any of those medications, it can be immune suppressing and increase your risk of severe COVID-19. So in general, what should people at higher risk of serious illness with COVID-19 do? And I would say you should be just doing what everyone else is doing. I have some of the kind of general overview recommendations, and I think these are actually the most important things to do. They can be the easiest to forget to do as well. Washing your hands for at least 20 seconds. Avoid touching your eyes, nose, and mouth with unwashed hands especially. Avoid close contacts with people who are sick. Stay home when you are sick. Cover your cough or sneeze with a tissue, then throw the tissue in the trash. Clean and disinfect frequently touched objects. One of the other points I wanted to mention is that some of you may have noticed or have heard that there's been a big decrease in the amount of patients coming to the hospital or being seen in clinics currently. I wanted to make sure that it's realized that if you are a patient on medications, it's very important that you do not stop your medications without talking with your physician. If you're on high-risk medications that lower your immune system, it's very important that you do not stop them or decrease them on your own. Many people can be afraid of COVID-19, but it's important to realize that there are other illnesses, and you can make things worse if you decrease your medications on your own. Well-being is quite important these days. There are high risks of depression, anxiety, and alcohol use, especially when self-quarantine at home is happening. And so it's important that if you become unwell, if you are having issues with your mood, with anxiety, with alcohol, there are ways to get in touch with physicians. We are using telemedicine now, more virtual medicine, and we haven't stopped. If you have any of those alarm symptoms, it's very important that you go to the hospital, but also if you have symptoms of your underlying disease that aren't COVID related, you may need to go to the hospital as well. Speaking of medications, are there any medications that are unsafe to take during COVID-19? I just want to reiterate that no one should stop their URSO. No one should stop their OCA or Ocaliva. And despite what you hear about ACE inhibitors, do not stop them unless a physician specifically says it's okay. There has been some reports of non-steroidal anti-inflammatories causing people to have more severe COVID. It's not very substantiated, but in general, I usually say Tylenol is safer than NSAIDs, especially in patients with chronic liver disease. So I would say choose Tylenol over NSAIDs if you can. One of the questions that does come up, does COVID-19 cause liver disease? In general, the information is quite limited. When a patient does have COVID-19 and it's severe, I usually see increased liver serum tests. And that can be due to the actual virus being within the liver, but sometimes it's due to muscle injury as well. With SARS, which is that other type of coronavirus, patients with chronic liver disease they were more susceptible to further liver damage, but we're not really sure yet if it's the same with COVID-19. But it is it is good to look at the positive aspects. Most patients do recover from this disease without needing any special treatment. And speaking of that, are there any treatments for COVID-19? You may have heard about lots of treatments in the news, but there's no recommended treatment yet. There are a number of Health Canada approved trials. I couldn't include them all because it would just take up too many pages of my PowerPoint, but I've included a few of them. Hydroxychloroquine is being studied. Ribavirin is being studied. Lopinavir and ritonavir or Kaletra is being studied. Remdesivir, colchicine, tocilizumab, nitric oxide, convalescent plasma. And we are doing a trial here in Nova Scotia as well. It's a interventional trial looking at a number of different medications in patients with moderate to severe COVID-19. And we're looking at lopinavir, ritonavir, hydroxychloroquine, and baricitinib. And it is important to know that if you do have liver disease, and if you do get hospitalized, having liver disease does not exclude you from any of these trials. There is a guideline from the American Association from the Study of Liver Disease that does help patients with liver disease get into these trials if they're needed. So that's my quick presentation. I'm going to close down this live session, and I'm going to come back and be live in person, and people can comment any questions, and I'll answer them in a live format. So I'll be right back, and just log back on.